On this episode of the ASC Podcast with John Goehle, we discuss the latest news in the ASC industry, including an update on the non-compete regulations, and discuss patient transparency regarding the credentials of healthcare providers. We'll talk about some recent experiences of our podcast listeners, and in our focus segment, we'll discuss quality assessment and performance improvement program compliance.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsor, Surgical Information Systems, providing cutting-edge information solutions for surgery providers. Trivalence. Trivalence offers a comprehensive next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable data insights. MedServ, which is the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com.
Welcome to episode 221 of the ASC Podcast with John Goehle for May 16th, 2024, recording from our studios in Spencerport, New York. This is Sue Cronkite, co-host of the ASC Podcast with John Goehle and operations manager for Ambulatory Healthcare Strategies. We'd like to remind our listeners that the ASC regulatory environment is a rapidly evolving landscape, and the material presented in this episode is based on the most current information available as of the date of recording. As such, it's important to recognize that this information may be subject to change, and we advise all ASCs to stay up to date with the latest regulations and guidelines issued by the relevant regulatory bodies. Joining me today is John Goehle, the owner of Ambulatory Healthcare Strategies and one of the most respected experts in the ambulatory surgery industry. With over 30 years of experience, Mr. Goehle has authored over 10 books on the ASC industry and is a sought-after speaker on regulatory accreditation and finance issues.
This is our first episode since ASC 2024, Sue. Mm-hmm. You had to stay back in the studio here while the 12 of us from Ambulatory Healthcare Strategies had the opportunity to go off to Orlando. It was a wonderful conference. Hopefully everybody enjoyed the 3 episodes that we recorded from there. And Sue, thank you very much for editing all those things on a timely basis so we could publish them for our listeners. It was a wonderful conference. In many ways, I think it's probably one of the best conferences that I had ever attended from ASCA, and I think many of the attendees will validate that. And we certainly had a lot of fun with our live podcast there. Mm-hmm. It was also great to see our wonderful sponsors there, SIS, Trivalence, and MedServ. They are a very valuable part of the podcast, and I do, as always, like to thank them for supporting us and for providing us great content. We did have 12 of our staff members from Ambulatory Healthcare Strategies during the conference, and we did have an opportunity to see many of our listeners from the podcast, and of course tell some people that didn't even know there was a podcast. Hard to believe that now, but didn't even know there was a podcast to hopefully become future listeners, and we have seen our listener numbers increase slightly after ASCA, so I do think that's happened. But we have been very busy since then. That's one of the reasons that it's taken so long to get this episode out. And we certainly have a lot of information to give to you in this episode. A couple of things that are going on. First of all, we have scheduled the multi-state conference. You might remember that we did the multi-state conference in cooperation with 5 state associations in June of 2023. We're going to be moving it to November. So it's going to be November 14th and 15th. More information to come on that. It is going to be free for members of the state associations that sign up with us. So we're still working on getting as many state associations to help sponsor this program. So if you are a member of these state associations, certainly reach out to them and tell them that you're interested in participating in the multi-state conference. And it is also free for patron members of the podcast. And we talk quite a bit about the advantages of patron membership. But if you haven't learned about that yet, definitely go to our our website at ascpodcast.com. We're also in the process of scheduling our first Life Safety 101 conference. That's going to be on November 12th, 2024. And by the way, our DON bootcamp, which is in 2 weeks, May 28th through the 31st, is our biggest one ever, Sue. It's going to actually break all kinds of records, which I was talking to a colleague of mine. I was kind of saying, I think when we started these boot camps, we thought that they might start to, peter out after a while, and that indeed has not happened at all. So I'm glad to see that this is a very popular event, and if you want more information about it, go to ASC-Central.com. We still have some slots available. I'll be heading down to New Jersey next week. I'm going to be talking about financial benchmarking, and we're also going to record a special New Jersey Association meeting episode there, as we always do. So look forward to seeing our listeners that hail from the state of New Jersey. And yesterday, Sue, I was in Albany, New York, lobbying on behalf of the New York State Association of Ambulatory Surgery Centers. One of the things that we were talking about, Sue, was cardiology. We know that when in 2021, when Medicare approved certain cardiology procedures to be performed in ASCs, not all states allowed it, and New York is one of those. But it was interesting to talk to state legislators about this, talk to the Department of Health about this, because it's definitely something that can improve access for individuals with cardiology issues. And I think there was a lot of interest on it. Now it's just a matter of trying to get these government agencies and legislators to come on board and make sure this happens. And again, most states do allow cardiology in the surgery centers, but there are a couple that at this point are not. And this has been a topic of ongoing conversations during our Saturday morning sessions with our patron members. And lastly, one of the things I talked about during our visit to Albany was transparency in healthcare. We know now as providers, including nurses, are getting more advanced degrees such as doctorates, the public is getting confused. For example, you can have a doctorate in nursing, and it's very important that our patients understand the differences between the different types of credentials out there. And there has been some confusion. As a matter of fact, there's been some studies out there that show that patients are confused about the various credentials and who is a doctor and who's not a doctor. We need to make sure that our staff properly identifies themselves and their roles, and they need to, wear name badges with their credentials on there. Now, not all states require name badges. And the accreditation organizations don't all require this. So, but it certainly is something that I really recommend, and also recommend making sure your employees, when they are introducing themselves to patients, are very careful about describing their role in the patient care team. And what makes this a little bit more difficult is the standards and the regulations are not very clear about the way we should be identifying ourselves to our patients. But we do have a personal and an ethical responsibility to make sure your patients know who we are and how we fit into that patient care team. For example, AAHC standard PRR 210.50 states that patients need to be provided information about the credentials of the healthcare professionals. Now, in looking at the various accreditation organizations, I think AAHC has the most definitive description of what needs to be done. When I looked at Joint Commission, it does require patients to know the name of their healthcare providers, but to the best of my knowledge, they don't require them to actually state exactly what their credentials are. But as I said, Sue, I think you'll agree this is really an ethical issue here, and making sure that the patients really truly understand who's involved in their patient care team.
And sometimes it just has to do with, even though you go in and you introduce yourself, they might kind of forget because they've met 5 different people. So,
right.
Some places will do different color scrubs for the different, for the tech and the nurse and the doctor. Or posting, pictures with the name and titles under each thing, as well as obviously your name tag.
Yeah.
But, and just explaining when you meet them. But I think sometimes that's when they're nervous and they're meeting so many people, they don't really retain that.
So, Sue, let's move on to some recent news.
Okay, so KFF Health News reported that the World Health Organization has declared that respiratory illness, including COVID, is spread by airborne transmission rather than droplets on the surface. Now, I don't think this is shocking for anybody. It may seem kind of obvious, and many researchers have believed this for quite some time anyways, as being the main form of transmission for respiratory illness. But the World Health Organization had not acknowledged this until recently, which kind of led to some poor decision-making during the pandemic. I remember wiping down my groceries, leaving them on the front porch. I think it didn't have to be refrigerated. So
it did, and it took us a couple days to be able to eat the food
Yes.
that you ordered. So, yeah, and now in retrospect, that does seem kind of silly. But again, we didn't know what was going on.
Yeah, and when you have these guidelines out there,
right.
People use them to make these decisions. So even though it's not, earth-shattering, it's important that they've made that sort of declaration or whatever. And they also have an online tool called ARIA, Airborne Risk Indoor Assessment, to estimate the risk of contracting a virus during an event. We are including that link, but I went through those steps, and oh my gosh, it's so detailed. You put in the size of the windows, if you're going to have windows, how open they are, half, 3/4, 1 bit. Are you going to be 5 feet from somebody talking? Are they going to be singing? Are they going to be yelling? It was really, really in depth, but I just kind of did a sample thing and it looked. And then you pick do some of the people actually have COVID, or is it unknown? And actually, the risk came out pretty low for the one I did, but it was kind of interesting. But I'm not sure most of us would have all that information about anything. But if you were planning something, I suppose if nothing else, it gives you a way to kind of, play with it and see, like, okay, if I have a few windows open, or separate people a little more or something. But
I think it makes us better prepared for the future if indeed we have another respiratory and
because it is just
pandemic.
respiratory. They're not specifically only talking about COVID. So that's good. And in OR Manager from 417, they presented a study that concluded that giving patients propofol before a colonoscopy enables better detection of certain types of polyps. Serrated polyps tend to be flatter and they blend into the surrounding tissue. So they theorize that increasing patient comfort and relaxation may allow for a more thorough exam, and also that smooth muscle relaxation may allow for better visualization, resulting in a 13% higher rate of these particular ones, serrated polyp detection. Propofol use has been linked before with better patient and provider satisfaction rates, but I believe this is the first study to show improved diagnostic outcomes.
So this is an argument moving toward having anesthesia providers providing sedation during these procedures, as opposed to a bit of a movement in some areas to conscious sedation. So something to watch out for. I personally feel that CRNA or anesthesia, administered anesthesia for these GI procedures is probably the better care for the patient. It looks like this study verifies that there's actually a good clinical outcome from it.
Aside from the whole, nobody wants to experience that any more than they have to.
That's
so
right.
It's just, make everybody comfortable. The Federal Trade Commission has adopted a ban on non-competes that will go into effect on September 4th of this year. They estimated that 18% of all U.S. workers are covered by non-competes, which equals 30 million people. The FTC expects that this change will lead to higher wages, and they actually estimated an extra $524 per year for some of those workers, more new businesses, and more innovation that could result in up to an additional 5,000 new patents in the first year. This doesn't count for senior executives, who will only make up about 1% of workers. For those people, existing non-competes will stay in effect.
So that would mean a lot of our higher level individuals, such as the directors of nursing and the administrators, would still not be covered by these non-competes.
You have to be above a certain salary and then also have policy-making ability. So there was a specific thing. And just following up on this, I saw in Becker's Spine Review from May 6th a physician's opinion on the non-compete ban. So Richard Cube, and I may not be saying that right, the second of Prairie Spine and Pain Institute in Peoria, Illinois, he feels that banning non-compete language in contracts is going too far and is not necessary, as healthcare workers and providers have a choice when they're signing a contract, and they could negotiate if they had concerns and just not sign that. He has concerns about smaller practices who invest large amounts of money in bringing new physicians into their centers, and that now there's going to be no way to protect that investment. And I'm just a quote from him. The bottom line is, without a way to protect an investment in new employees, there's no incentive to hire them. There is zero chance we will hire new docs if we cannot protect our investment. This will cause small practices to go extinct over time. Now, I don't know, what your opinion is on that, John, but I hadn't really seen. I always felt it was a good thing to not have non-competes, so people are free to go where they want to go. But he kind of had a good point there, too.
Yeah, I guess it depends on which side you're on. If you're the employee, you don't want a non-compete. Yeah. I've had non-competes over the years as the administrator. It sounds like I would have been exempt from that, or in other words, they would be able to enforce that agreement. Yeah. But I do see where we as a surgery center, if we can enforce a non-compete, with our employees, that would make it more difficult for them to, jump ship and go to another center just for dollars. And we know that's happening right now. That people are leaving.
Yeah, a lot of people don't stay very long in a particular job. And it's one thing if they come in and they're pretty well trained. Right. But if you invest in a provider and maybe get the equipment that he or she wants, and all that kind of thing, and then they're out of there in a year, it makes it kind of difficult. Yeah,
and again, it goes to all levels, even nursing right now. I think that especially when you're paying the cost of education for them or some additional training, that could really put a damper on your ability to provide that additional incentive for them to come to work for you.
And I saw a survey from AMN Healthcare of registered nurses. So they surveyed 18,000 RNs in 2023, and here's some of what they found out. So although nurses' career satisfaction has been 80 to 85% for the last decade, it dropped to 71% in 2023. The nurses in the survey were also 14% less likely to encourage others to become nurses than they were in 2021, which is interesting because it kind of used to be nurses loved being nurses, and they would, kind of recommend it to almost anybody who was interested.
And you see it within families, such as yourself and your daughter. You found multiple generations of people going into that career. Yeah. So this is a sad development.
Maybe changing. 36% of hospital nurses said that they will be looking for a new place to work, but will continue nursing, while only 15% expected to continue where they are. So
that's a good opportunity, right?
Yes.
A good opportunity
Watch for those hospital nurses flocking away. 94% agree that there's a severe or moderate shortage of nurses in their area, with half of them saying that they expect the shortage will get much worse.
Yeah, and I think that we've definitely seen that. So we definitely need to work on, nursing satisfaction with their jobs. But I do think part of it is that their work's so hard right now. I mean, we can see it in an organization.
Yeah, the shortage just I don't know, snowballs.
Right,
The shorter you are, the more stressed people are and all of that. But there's good news about nursing. The 2023 Gallup's Honesty and Ethics poll results showed that nurses are, again, the highest rated profession. So 23 professions are rated, and nearly all ratings have declined. The lowest rated were advertisers, car salespeople, senators at 8%, and all those are at 8%. And the lowest were members of Congress at 6%.
I guess we won't make any comment about that, but certainly doesn't bode well for the elections.
Although even nurse ratings have declined 11 points for 2020 with a current rating of 78%, they still have the highest rating for the 22nd consecutive year. So that's really good.
That is impressive.
Very trusted by people, and it kind of makes you proud to do your job and be that patient advocate.
So let's talk about some recent issues that we've encountered. A lot of these come from our Saturday drop-in sessions when we talk to some of our attendees, our patron members, as well as things that we encounter through our business here. So I did have an opportunity to speak to some representatives from the National Practitioner Data Bank at ASCA 2024, and I followed up with a telephone call to them early this week. We hope to have them on an upcoming episode. Unfortunately, because the NPDB is part of the government, there are some steps I have to jump through, Sue, before I can get them on. Actually, I'll make you do all that. But we hope to invite them on to talk about the data bank and to solve some of the problems. Apparently, a number of people went to the booth that they had at ASCA 2024 and mentioned that they're often have problems in signing up. The representatives there answered a lot of questions about how to register for the NPDB, and they helped them through the process. And they did follow up on with each of those attendees in writing in an email. And this reminded me that the NPDB responds very rapidly to questions at their help desk. So I'm going to give you a link to the help desk in the show notes. It's help@npdb.hrsa.gov. By the way, Sue, they were wonderful people. They really were very anxious to help out. I was very excited about having them at a conference for surgery centers. You know, you kind of expect them to go to the bigger conferences like hospital conferences, but it was very nice to have them there. And as I said, we're going to try to have them on an upcoming episode, and maybe we'll even be able to get them at our multi-state conference in November. Another issue came up recently. We had a question about email meetings, and it was noted that some centers have asked if they were allowed. The answer to that is generally no. So you can't send an email out to all of your board members and call that a board of directors meeting. So for a true governing body meeting, you're going to have to meet in person or virtually where everybody can see each other. You do need to check your state regulations. And by the way, one thing I learned in doing a little bit of research in this area is that you have to be very careful about what the regulations are in your state for virtual meetings. So make sure that both your medical staff bylaws, by the way, as well as your governing body meetings comply with those regulations. So definitely make sure you talk to your attorney about what the regulations are in your state. And so another thing that keeps happening, especially when people approach me, when owners approach me about hiring a new director of nursing or a new administrator, they say, "Can you give me a checklist of all the responsibilities of an administrator or a DON?" And we kind of have to laugh at this. My simple answer to this is somewhat sarcastic in saying, well, the best way to determine what your the responsibilities are to read the conditions for coverage, the interpreted guidelines, state regulations, and the various accreditation standards, depending upon what accreditation organization you have.
I do understand people wanting that. It's such a complicated role, and we really can't tell you everything that you would need to do. It all depends on your center. It depends on the things that come up. You're just working on the fly sometimes, but it's not like you're doing. I understand the request.
Right. It's not like you're doing a checklist. It's not like you can run down a list and say, "This is what my responsibility is." So much of what, and again, I was an administrator for a good 18 years before I went into my current role full time. But maybe what you could put down in a checklist would be 5% of your time. The other 95% is dealing with the day-to-day things that happen in your organization, often many of which you can't predict. So just keep that in mind. And another issue that's come up recently is facility maintenance records. And just want to remind our listeners that the ASC has to maintain the records even if the landlord is responsible for doing certain things. For example, you might have the landlord maintaining your generator or your fire alarm or your security system or your sprinkler system. You can't tell the surveyors, well, that's not my responsibility, the landlord takes care of it. Or you can't rely upon them to be available during a survey to be able to show all those records. Not to mention what happens if the surveyor looks at those records and you find out, that those records were incomplete. So just a note to make sure that you maintain copies of any records that your landlord might maintain for things that are included in your life safety survey. So, Sue, when I was looking at a list of all of the episodes and what we've talked about recently, I noted that we have not talked about quality improvement or quality assurance and risk management recently. So I thought we would do a deep dive into that during our focus segment. So let's take a short break, and when we come back, we'll talk about how to maintain regulatory compliance with your QAPI program. With the rapid changes occurring in the ASC industry, the exodus of experienced ASC administrators, nurse managers, and business office managers, there is an increasing demand for quality leadership education. That's where our industry-leading boot camps come in. In 2021, we introduced our Administrator Boot Camp and the Director of Nursing Boot Camp, and in 2023, the Business Office Manager Boot Camp. These boot camps have become the industry standard for ASC leadership training, and with over 225 graduates, lead the industry in mentored virtual training.
Live virtual training for the Administrator Boot Camp occurs every January and July, and the Director of Nursing Boot Camp is October and May. Our new Business Office Manager Boot Camp will continue in the spring of 2024. There are also on-demand versions of each boot camp for those who simply can't attend the live virtual programs.
All boot camps, including the on-demand boot camps, include access to resources, membership in the ASC-Central Patron Program, copies of John's latest books, access to credentialing, conditions for coverage, and other recorded training programs, and of course our regular drop-in Zoom sessions where you can ask questions and interact with other patron and boot camp members.
Our programs also include AEU credits for those that are CASC certified. Our programs are comprehensive and taught by the nation's leading ASC experts and are designed for all levels of leadership, from experienced leaders who want to enhance their skills or pass the CASC exam, or those who are new to the industry and wish to learn how to run an ASC.
For more information about our live, virtual, and on-demand programs, visit ASC-Central at asc-central.com. Or you can call us at 585-594-1167 or email us at info@ascpodcast.com for more information. So, as we always do when we're talking about regulatory requirements, we want to start by putting it in perspective, by referring back to the Medicare conditions for coverage. And for those that are new to the industry or are not familiar with Medicare regulations, the Medicare regulations are what we refer to as the Medicare conditions for coverage, and they're included in Part 416 of the Federal Code of Regulations. So, Sue, why don't you start with the condition for coverage related to the Quality Assessment and Performance Improvement Program?
Okay, so that's Section 416.43, Condition for Coverage, Quality Assessment, and Performance Improvement. The ASC must develop, implement, and maintain an ongoing data-driven quality assessment and performance improvement, or QAPI program. And the interpretive guidelines for that, the QAPI Conditions for Coverage, requires an ASC to take a proactive, comprehensive, and ongoing, we hear that word ongoing over and over, approach to improving the quality and safety of the surgical services it delivers. The conditions for coverage presumes that ASCs employ a systems approach to evaluating their systems and processes, identifying problems that have occurred or that potentially might result from the ASC's practices, and getting to root causes of problems rather than just superficially addressing one problem at a time. From a survey perspective, the focus of the QAPI condition is not on whether an ASC has any deficient practices, but rather on whether it has an effective, ongoing system in place for identifying problematic events, policies, or practices, and taking actions to remedy them. And then following up on these remedial actions to determine if they were effective in improving performance and quality. QAPI programs work best in an environment that fixes problems rather than assigning blame.
So there's a lot to uncover or to pull apart in that. So, Sue, as you mentioned, ongoing is really one of the most important things here. This is not something you do just before the next survey. It's something that has to be done on a monthly basis, on a quarterly basis, on an annual basis. You need to be looking at this data, evaluating and having regular meetings of your Quality Improvement Committee, making sure that the meetings of the Quality Improvement Committee are reported up to the governing body on a regular basis, not just annually, on a regular basis, and that any actions that need to be taken as a result of the findings of the Quality Improvement Committee are reported to the governing body so that they can take appropriate action. I can give you a couple examples. I remember I did a due diligence for an organization that one of our clients was looking to purchase. And when I asked them about what they had in place for quality improvement, they pointed to these quality improvement studies. And I said, well, that's great. That's quality improvement study, but that's not your quality program. And they were very confused. They thought quality improvement was only quality improvement studies, and that was the extent of their entire quality improvement program. Needless to say, they didn't do very well in their next survey, which was shortly after I visited them for that due diligence. And you need to make sure that your governing body takes this seriously. One thing that I always recommend is that make sure the first agenda item on every one of your governing body meetings is quality improvement, to demonstrate to surveyors who are reviewing those minutes that this is something that's first and foremost in the minds of the governing body. And I get it. The governing body likes to know what their next distribution is going to be. They want to be able to address financial issues, but it's extremely important for them to understand that there are very specific regulations, as we've just indicated, that the governing body has to oversee with regard to this program. One thing that you mentioned was, from a survey perspective, the focus of the QAPI condition is not whether an ASC has any deficient practices, but rather on whether it has an effective ongoing system in place for identifying those events and taking actions to remedy them. And I think that's one misconception that a lot of people have in surgery centers, is that they're afraid to report things to quality improvement because they think that the next survey they're going to get into trouble. And it's actually quite the opposite. If I go into a center and I see that you haven't had any incidents, that you haven't had anything go wrong, or at least according to your documentation, you have anything gone wrong over the last 3 years, I'm going to be very suspicious, because even the best centers are going to have things that they didn't anticipate happening that involve patient care. Yeah,
something they can improve upon. That's the whole point of doing this.
Right. And we as surveyors are not in there to ding them for that occurring, but we will ding them if they didn't identify that issue, look into it deeply to determine whether there's anything they could have done to assure that it doesn't happen in the future, or to make sure that they minimize the possibility of it happening in the future. So again, a surveyor isn't there to punish you for having a patient event, but they are there to make sure that you have identified those patient events and followed up appropriately. And that really gets to that last sentence that you said there, Sue, from the interpretive guidelines. QAPI programs work best in an environment that fixes problems rather than assigning blame. And again, that's so important, is making sure that as a result of the that quality improvement meetings are a safe place, that you talk about what's going on, you don't try to blame people, and you try to find if there's a systemic problem that caused it. So let's talk a little bit about the importance of identifying opportunities for improvement, which is one of the most important aspects of a quality improvement program. There are many mechanisms for identifying opportunities for improvement, and developing a robust QAPI program that will have a wide variety of such mechanisms. And a robust QAPI program is going to have a wide variety of such mechanisms. So let's just mention some of the most common in an ambulatory surgery center. Incident reporting, though, of course, I think is probably one of the primary ones, where we identify events that have occurred that we didn't expect. And these are not just events that occur that impacted the patient. It could be something that impacted equipment. We had an issue recently where an organization had to shut down because they had no power in the building. Well, that was an incident report. What could they have done to assure that power didn't go out? After they did an investigation, they identified some specific issues that caused the system to shut down. But and that hopefully improved quality improvement in the future.
And it is okay if sometimes there really is nothing you could have done to have prevented something, but at least you're looking into this. You're never letting an opportunity go by where you could possibly improve things.
Right. Well, and another example of that could be if you had a flood. Maybe you didn't do anything to cause the flood. It was a natural occurrence. But how did you respond to it? Did you quickly identify a way to minimize the damage in the organization? Do you have processes in place to assure that you more rapidly identify that you have a problem? And are there certain things that you want to protect? For example, we had a surgery center that twice in a row flooding occurred that wiped out their battery operator, their UPS system. One of the outcomes of the incident report from that second event was maybe it's time to move that UPS system out of the basement where it's more likely to be flooded. Incident reporting is going to involve also a review of all the transfers to the hospital of any of your patients, emergency room visits, et cetera, as well as other things that you can include there are equipment malfunctions that resulted in a delay in a patient case or canceling of a patient case, and it might even include cancellations upon arrival at the surgery center. What I like to do is the way I look at it is with incident reporting, I keep lowering the bar until we have like 5, to 10 incidents minimum for a quarter so that you have something to report on. So if you don't have a lot of things that go wrong, and knock on wood, in your organization, just keep lowering the bar. Maybe it comes down to, if everything is, if you're doing a very low volume of cases and you don't really have a lot of things that unusual happens, keep lowering the bar until you identify things that you can improve upon. Yeah. A good quality improvement program is going to look for every opportunity possible in your organization to improve the quality of the patient experience.
And near misses, of course.
Yes, that's right. So, that's another good example.
Maybe something happened, but somebody came close and someone identified it, but then back it up and could somebody have found it sooner so that the next time it doesn't slip through.
And then moving on and continuing with what are some of the more common mechanisms, including your quality improvement program. Chart audits is another primary one. Having your nurses do chart audits, for example, to make sure that the charting of the patient event is done properly, that the sign-offs are appropriate, that you have proper documentation of a patient's allergies and reactions to those allergies. They have proper documentation of everything that occurred in the pre-op, the post-op, in the intraoperative experience there. And not just nursing chart audits. You're going to want to have physicians, of course, do chart audits, peer review it, that is. Your anesthesiologists need to be doing chart audits also. And maybe you're going to hire an outside medical record consultant, for example, also to do a chart audit to look at it from a medical legal standpoint. Satisfaction surveys are another very critical part. What is the patient experience? What is their perception of that experience afterwards? And those satisfaction surveys should be developed in such a way to identify, all different parts of the patient experience, from the patient being scheduled for the case to discharge, even to the follow-up afterwards. We've talked quite a bit about OAS caps and how that's going to change the industry quite a bit, but OAS caps, because you're going to be required to hire an outside company to do your satisfaction surveys, will instantly give you the ability to be able to do benchmarking against other organizations. So I think, for all the difficulty that I think OAS caps is going to have for our centers, I think we're going to get much more interesting information and maybe perhaps actionable information. A very important part of quality improvement, of course, is infection control oversight and surveillance, making sure that you identify infections, that you identify opportunities for improvement in that area, make sure that your employees have appropriate training, and that you're surveilling. You're having somebody that's looking at hand hygiene. They're looking at sharp safety. They're looking at the environment of care to identify things that could result in the patient having an infection. Environmental rounds, walking around and making sure from a safety standpoint that exits are properly labeled and kept clear, that the place is kept clean. That's not just from an infection control standpoint, but also from a patient experience standpoint. Monitoring your cancellations. Cancellations result in not a great patient experience. And, of course, physicians are upset when a cancellation occurs. Now, many of these cancellations are not avoidable. A patient comes in and is sick, or they have to cancel on the day of surgery because they're sick. But if a patient shows up, for example, for a GI procedure and didn't have an appropriate prep done, you should be learning from that. You should be monitoring how frequently a patient arrives without having a proper prep done. Or another situation could be a patient being canceled because they have a cardiac issue that was not cleared prior to the procedure. If you identify that there's an increase in the number of these cancellations, you're going to want to look into ways in order to reduce that, to improve the quality in your organization. You also want to make sure that you're tracking and trending the results of all of these quality improvement activities. This is known as internal benchmarking. where you're looking at like your infection rate over a period of time. Has it gone up? Is it continuing to go down? Is it staying steady? Wherever it is, you need to make sure that you're comparing yourself against yourself internally to determine what your trends are. And external benchmarking is also important, where you're comparing your statistics to outside organizations, such as how does your infection rate compare to other surgery centers? And you can get all kinds of different sources of external benchmarking, including, ASCA, of course, has their operational benchmarking. We have some of the state associations, for example, Ohio and California have excellent external benchmarking programs. But Sue, I think arguably the most important part of quality improvement is what we mentioned in the beginning, and that's incident reporting. It requires good communication. It requires you to communicate to your staff, to your doctors, the importance of incident reporting and their role in identifying incidents that occur. You really do need to encourage people to report it, that they're not going to get into trouble for reporting these things. They're not going to get into trouble for having an adverse event. And recognize that that adverse events are not the only thing that drive an incident report. I think many physicians, because of their hospital experiences, often think that an incident is always a bad event or always something that involves patient care, and that's not always the case. A good incident reporting system will encourage people to report things that fall outside of those normal parameters. And so, for example, the obvious ones, as we mentioned, are transfers to the hospital or surgical complications or anesthesia complications or other clinical incidents. But there's some not so obvious incidents, such as equipment breakdowns I mentioned earlier, communication breakdowns. Maybe you failed or somebody failed to communicate to the post-op team what happened during the intraoperative event. Maybe you have cleaning issues. Maybe, and this often ends up from a communication problem, that your nursing staff identifies that there was that the evening cleaning team didn't do a good job of cleaning. Well, if you don't communicate that through the appropriate channels to the cleaners, you might find yourself not fixing that problem. And lastly, I think I just want to really kind of emphasize the importance of developing a culture of quality. And that involves, of course, good employee education. Every year you should be explaining to your employees how your quality improvement program works and making sure that you develop a team approach to identifying, researching, fixing, and communicating changes to your operations. So what do you do with all this information? Well, you should be having a minimum of quarterly quality improvement meetings, and those meetings should involve a wide range of people from your organization. Obviously, the medical director, the director of nursing, the administrator needs to be involved in those meetings, but a good representation from your nursing staff, from the pre-op, inter-op, post-op, people from your sterile processing, people from your business office, maybe even somebody from your registration function, your billing function. The more that you have involved, without getting too big so that you don't have productive meetings, but the more that you encourage people to participate in this process, the more likely you're going to have a good, robust program. And again, I just want to go back to my very beginning when I mentioned how important it is that you take the results of the quality improvement meeting and report it to the governing body. That is one of the standards. That's one of the requirements of your regulations, is that all of the results of quality improvement are reported up to the governing body so that they can take appropriate action. So examples of appropriate action might be changes in policy or assuring that your educational program has changed. Or in the case where people continue to do something wrong, maybe you're going to have to do discipline either of your employees or of your physician staff if they were involved in whatever occurred that should not have occurred. So hopefully that's given you a good background in quality improvement. We do have some great programs. Obviously, our boot camps talk quite a bit about quality improvement programs. And for more information about all of our boot camps, visit us at ASC-Central.com. Let's take a short break, and when we come back, we'll talk about what's coming up in the ASC industry.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff, and other events in the ASC industry.
And of course, as we mentioned earlier, the New Jersey Association of ASCs annual conference will be May 22nd through the 23rd, 2024 at the Palace at Somerset Park. I'll be speaking there about benchmarking, and we're also going to have a booth, and of course, we'll also be recording one of our live podcasts from there, as we always do with New Jersey.
And our DON Nursing Leader Bootcamp is May 28th through the 31st, 2024. And you can find more information on ASC-Central.com.
And it's important for us to remind you that that is a virtual conference, and it is more than just that event. You know, in addition to the 4 days done virtually, there are optional weekly drop-in sessions for all the attendees. And the Gulf States Conference is June 11th through the 13th, 2024 in Biloxi, Mississippi at the Beau Rivage Resort and Casino.
And Becker's Spine, Orthopedic, and Pain Management-driven ASC Conference is June 19th through the 22nd in Chicago at the Swiss Hotel.
The Ambulatory Surgery Center Administrators Virtual Boot Camp is going to be July 16th through the 19th, 2024, presented by ASC-Central and, of course, the ASC Podcast with John Goehle. For more information, go to ASC-Central.com.
The Florida Society of Ambulatory Surgical Centers Annual Conference and Trade Show is July 17th through the 19th, 2024, in Orlando, Florida, at the Signia by Hilton Orlando Bonnet Creek.
The Texas Ambulatory Surgery Center Society's annual conference is July 24th through the 26th in Galveston, Texas, at the San Luis Resort, Spa, and Conference Center.
The Georgia Society of ASCs and South Carolina's ASC Association's joint semi-annual conference and trade show is August 15th and 16th in Hilton Head, South Carolina at the Marriott Hilton Head Resort and Spa.
And the 2024 Illinois Association of Ambulatory Surgery Centers annual meeting is going to be held August 22nd to the 23rd, 2024 at the Crown Plaza at the Chicago O'Hare Hotel in Rosemont, Illinois. And I'm going to be doing something very unique there. We're going to be doing an ASC Administrators Workshop. It's a 4-hour workshop. We've done something similar for finance, but this will be the first time we've done one for a state association for administrators. I'm very much looking forward to that.
And the California Ambulatory Surgery Association's annual conference is September 4th through the 6th in Anaheim, California at the Anaheim Marriott.
And we're still working with CASA on that. We will be there, most likely doing a podcast. And the Tennessee Ambulatory Surgery Center Association's annual conference is September 12th through the 13th in Chattanooga, Tennessee at the Chattanoogan.
And the New York State Association of Ambulatory Surgery Centers annual conference is September 17th and 18th at the Desmond Hotel in Albany, New York. And AHS will be doing the pre-conference, which is 3 hours of educational material.
That's right. We're going to be talking about infection control, HIPAA, and a survey update. And also at the annual meeting of the New York State Association, we also do our annual meeting of our New York State clients, also at the Desmond Hotel.
Okay, so, and that'll be on Monday the 16th.
That's correct. That's correct.
Pre-conference.
And the Becker's ASC 30th Annual Meeting, also known as the Business and Operations of ASCs, is October 30th through November 2nd in Chicago, Illinois at the Hyatt Regency.
And the Washington Ambulatory Surgery Association's 2024 Annual Education Conference and Trade Show will be November 7th and 8th at the Tulalip Resort and Spa in Tulalip, Washington. And John will be speaking about accreditation and will provide an update on accreditation trends.
Sue, we should mention that for years we've been calling it Tulalip, and it was during my visit there last year that I learned that I was been mispronouncing it for years. So we apologize.
I love saying that.
I know.
Tulalip, I thought was really a nice
well,
little word.
Tulalip is just
wonderful
nice.
too.
And don't forget, on-demand versions of the ASC Director of Nursing, ASC Administrators Bootcamp, and our Business Office Managers Bootcamp are available on our sister website at asc-central.com. And, of course, as we've referred to a couple times, a reminder for everyone to become a patron member of the podcast. We have almost 200 patron members now. And the patron member program, which is hosted on asc-central.com, is an exclusive membership website and an experience that provides a one-stop ASC regulatory and accreditation compliance, operations, and financial management resource for busy administrators, nurse managers, and business office managers. And in addition to our regular, usually weekly drop-in Zoom sessions on Saturday mornings with other patron members and the staff of the podcast, there's additional patron resources that include access to some of our virtual conferences, including the Credentialing Conference, Conditions for Coverage Conference, and Finance 101. It also includes example policies and procedures, example forms, and our famous fire and disaster drill kits. Membership helps to defray the costs of producing this podcast, including our research staff, travel costs to the conferences, equipment costs, and production costs. For more information, please visit ASC-Central.com. Thank you for joining us for this episode of the ASC Podcast with John Goehle. If you found this episode informative, we encourage you to share it with your friends and colleagues in the ASC industry. And don't forget to hit that subscribe button so you never miss an episode. We'd love to have any feedback that you can give us about our episode or ideas for future episodes by sending us an email at comments@ascpodcast.com.
And we'd like to give a special thank you to our great team here who make this podcast possible. Our sound editor, Susan Cronkite, our executive producer, John Goehle, and our dedicated research team, Sue Cronkite, Jenna Alvarez, Judy D'Ambrosio, Mike D'Ambrosio, Alex Borneman, Zach Caloridis, Jim Masters, Amy Cronkite, Lori Rodricks, Kathy Fody, Donna Macchio, and Christina Norman. We couldn't do it without them. Our music is provided by Media Sushi and Mike Noah, and the ASC Podcast with John Goehle is hosted on Podbean and is available on all major podcast platforms. Thank you for listening.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, providing cutting-edge information solutions for surgery providers. Trivalence, offering a comprehensive and next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable data insights. MedServe, which offers the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies, which is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For information about any of our sponsors, please visit our website at ascpodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. And we'd love to hear your questions and comments. Please email us at comments@ascpodcast.com.